Yeah. So good evening, everyone. It is my pleasure to welcome you all to Lipitas lecture series, a focused academic initiative by the Nexa division of Intas Pharmaceuticals. As healthcare professionals, we find ourselves at the forefront of constantly evolving cardiometabolic landscape. The burden of dyslipidemia and its cascading impact on cardiovascular outcomes continue to challenge us, especially in the high-risk populations. The objective of this platform is to bring together the leading experts in the field of cardiology to share evolving insights on lipid management and cardiovascular risk. So without taking much time, it is my honor to invite and introduce the chairperson of our today's sessions, both the sessions, Dr. Vijay Kumar Trehan. Dr. Trehan is a professor and senior interventional cardiologist and ex-director professor HOD Cardiology Department at GP Pant Hospital, New Delhi. Dr. Trehan has trained more than 200 cardiologists who are working at various posts in all over India and abroad. Dr. Trehan has been examiner for postdoctoral DM cardio or fellowship in various premier top institutes across the country like AIMS, PGI, HGPGI, Sri Jayadeva Hospital, etc. for over 20 years. Dr. Trehan has received numerous awards by Government of India and the MCI for the development in the field of cardiology. He is regularly delivering guest lectures at most of the national and international conferences and workshops. Dr. Trehan has been performing live case interventional cardiology in national and international level workshops as well. And Dr. Trehan is noted as one of the best recognized operators for balloon mitral valvotomy, and he is holder of the world record in Limca Book of Records for this. So I welcome Dr. Trehan, and now I would request Dr. Trehan to introduce our both the speakers for our today's sessions. So it's over to you, sir.
So thank you very much. I think this was too elaborate an introduction of mine, and but I think the other two speakers who are here, they probably, if you start reading their achievements, I think it will take the whole time, an hour to complete. And Dr. Rajiv Agrawal is a dear friend of mine who is presently working in Max Saket as the principal director and unit head. And needless to say that he's one of the most meritorious uh, cardiologist and has worked outside India as well as in India and has done a lot of interventional work. And I remember he has participated in writing one of the interventional book way back 3 decades ago. And he has an expertise in doing almost everything, which includes coronary angioplasty, stenting, pacemakers, valvoplasty, and off late structural heart disease. He's also on the faculty of National Board and PGDCC, and has numerous papers, and he has been invited as one of the topmost persons to deliver guest lectures in various conferences in India and abroad. I think let me not take too much of time in trying to just introduce him, and it is our honor and privilege to listen to him, and he'll be talking to us about the LDLC as to is it still relevant, and do we still need to learn about it, and are we doing sufficient job in lowering LDLC, and if you're not doing the job, then how best we can do the job to have the LDLC at the lowermost level so that we are able to have our heart safe. So over to Dr. Rajiv, please.
Thank you. Thank you, Dr. Trehan, for that really effusive introduction. And but it's a privilege to share this platform with both yourself and our senior colleague, Dr. Piyush Jain. And the topic is, of course, very relevant. And I hope that most people who would be participating in this will have a working knowledge about lipids. But a lot of things do bear repetition and maybe some thought. So I will, without further ado, I will start my slides if I can share. Okay, this is it. Resume. Let me see. Does that work? Let me see. Yeah. So I hope my screen is visible in full screen.
It is not full screen, sir. So you have to make it to full screen.
Acha, because on
Yeah.
my screen it is full. Let me just
Just a
try
second.
to
There must
do
be
it
some
again. Cracking the code, then this one maybe. Is it full screen now?
Yeah, now it is perfect. Yeah.
Yeah, but now it's not moving. Let me see. Now it's not moving. Actually, I find once you've checked it once, then it creates a dummy and
Yeah.
view slides. Okay. Give me some good news now. Is it full? No.
Not yet, sir.
Uh, Otherwise, I'll have to probably sign out and sign in again because it may be.
I'll request you, to close the PPT and reopen it. So I mean, if that may work.
Yeah, yeah. But just give me a few seconds. I'll sign out also and then sign in again.
Oh. Perfect, sir. Now. Yeah.
Perfect.
Yeah.
Okay. Sorry about that. And so, having wasted a few minutes, let's start. So, the topic given to me is uh, sort of an overview about LDL cholesterol lowering and its position, cracking the code, trends, and barriers in LDL cholesterol lowering. What's next for heart health? That's actually quite a wide topic. Of course, what we actually do depends on what is doable. And some of these things are in the realm of science, and some of them are in the realm of the systems of care in terms of the implementation. And I think we need to understand both the things that where is the science? Is it all LDL? Are there changes in LDL which make differences? Are there other things in the lipid profile which matter? Are there other things apart from lipid profile which matter? Certainly, the answer to most of these questions is yes. And apart from the science, what is the practicability and the actual achievement that we are having, not just on the world level, but in the Indian context, where I think healthcare and especially preventive healthcare is so poor. So, one question which really interests me is, should we actually go for more and more aggressive targets when we are doing so poorly with even very modest targets? And which will be better, to go for the best care for a few patients or try to broad base it so that most patients get good care. So this is it. So this slide actually it taught me something because from Global Burden of Disease 2019, although India has now outstripped China in terms of population, but it seems that China still has higher CV death ratio than us. So that is at least one metric where we are doing better than China. But anyway, it's a dubious distinction. We are both right up there. So non-communicable diseases are the most important diseases in terms of morbidity and mortality. Of these, cardiovascular diseases, especially heart disease, is the most important, especially in the lower and middle income countries. I think in higher income countries, it is cancers which seem to be galloping ahead now. But at least in our part of the world, it is still cardiovascular disease. And so we have to look at the factors for this. And numerically, the most important factor is high systolic blood pressure, and this has been shown in multiple studies. So even modest elevation of blood pressure, which has no symptoms, will actually increase the risk of cardiovascular disease. And this is, although occult and not diagnosable by symptoms, it is eminently treatable. And this is one factor where we need to do better. Dietary risks, again, this is something which we can treat, and we can modify, and we should do better. And the number 3 factor, according to GBD, is the high LDL cholesterol. Again, something which can be modified both by lifestyle and by pharmacological measures. Chronically elevated LDL cholesterol drives the development and manifestation of atherosclerotic cardiovascular disease, the leading cause of mortality, which is responsible for approximately 1/3 of all deaths. So there you have it, that after the systolic blood pressure, this is the other pharmacological target that we have. And multiple strands of evidence show the importance of LDL cholesterol, and that LDL cholesterol is the most important cholesterol element that we have to worry about in terms of the lipids. Genetic studies confirm that patients who have some genetic disorders with low LDL levels will have reduced cardiovascular events. In meta-analysis, there is a consistent about 22% risk reduction for every millimole of LDL cholesterol reduction. So therefore, 20% leads to 40 milligram percent LDL reduction will lead to 20% reduction. So that's the ballpark figure. And LDL cholesterol accumulation promotes plaque development and progression, and imaging studies also validate the same thing. Imaging studies with high dose statins have actually shown some plaque regression, and plaque stabilization probably is more than this, because the reduction in clinical events is much more than would be expected by a few percentage points of plaque regression that we will get in these studies. But these studies are there, and if you want to achieve plaque regression, then you have to use aggressive lipid lowering therapy, including high dose statins, maybe combined with other drugs. And so we keep talking of pleiotropic effects. LDL cholesterol lowering will also lead to endothelial stabilization. Endothelial repair happens. It reduces inflammatory response. A lot of atherosclerosis is supposed to be related to the inflammatory markers. HSCRP is a risk marker and a risk factor. And the LDL cholesterol lowering will reduce the inflammation. So inflammation might be because of various factors, including LDL cholesterol. So again, it shows the centrality of LDL cholesterol reduction. And we have those primary prophylaxis studies which have shown that the intermediate risk patients who have even modestly elevated cholesterol, but they have high HSCRP, will be benefited by statin therapy, specifically by rosuvastatin therapy. Non-HDL-C, which will then include, say, triglyceride-rich lipoproteins, VLDL, etc. So basically, it will be about 30 milligrams percent higher than LDL cholesterol, is the next target. ApoB is also a target. Every LDL particle has an ApoB molecule. So therefore, in general, ApoB should give similar information to LDL. But the point is that in atherogenic dyslipidemia, and especially in the Indian type of dyslipidemia, you may have small dense LDL particles, so that the LDL cholesterol level itself may underestimate the degree of pathogenicity of that cholesterol. And so the ApoB particles might be something which might give some additional information. There are many other things in the in lipids, but the most of the impact and most of the treatable impact is there in the LDL cholesterol. So with that, of course, atherosclerosis is not just LDL. LDL may not be the only game in town, but it's very high up there. It is an enabler, if not the only cause. After SBP, it is the most important treatable factor. And so I've said all this. And also, some slides will come in the end which show that lower the better. Yes, lower the better. Fortunately, at achievable levels of cholesterol, we have not yet reached the J point at which below which it will be adverse to lower the LDL cholesterol. So the lower you lower the LDL cholesterol, even to levels below 30, the better is the patient. And side effects, although much feared, have not actually happened. But also the earlier the better. So the genetic studies suggest if you have lifelong lower cholesterol, you are better off. If you start lowering the LDL cholesterol in early adult life, or even in the 20s, you will reduce the chances of atherosclerotic heart disease much more than if you started to do so at the age of 60, say, where people start getting worried about their heart. So these are some of the factors. And of course, statins were game changers with HMG-CoA reductase. So we've had these since the 80s. And now we have stronger statins than the ones like lovastatin, etc., which were initially available. Those were really low intensity statins. Now we have high intensity statins, which will lower the LDL cholesterol by at least 50%. And these basically are rosuvastatin 20 or 40 milligrams, or atorvastatin 40 or 80 milligrams. All other statins would be considered to be either low intensity statins or moderate intensity statins. And the guidelines for lipid lowering have been constantly evolving from very liberal LDL levels to in ATP3, the LDL cholesterol less than 100 became a target for high-risk patients. Then there was some confusion with the 2013 guidelines where they said don't look at the LDL cholesterol level at all, just do an overall risk assessment. Fire and forget, don't look at the achieved LDL cholesterol. This was something which, as clinicians, none of us were very comfortable with. And fortunately, there has been a resurgence of the target-based strategies, especially with the ESC 2016 and 2019 guidelines. And now I think one figure that we can remember is an LDL of 70 for most patients, LDL of 55 for patients with established atherosclerotic disease, LDL below 40 for patients with recurrent coronary events. So that is something which we should remember. And also, fortunately, we have seen with many drugs, including ezetimibe and bempedoic acid, and then injectable medicines like PCSK9 and inclisiran, that it is not just statins which will improve the risk. LDL cholesterol lowered by any means will improve the risk. And in many patients who are not able to reach their LDL cholesterol goals with statin and lifestyle alone, these other drugs will be very useful. So obviously we have an escalating matrix. First, add oral drugs. Then, and especially in the higher risk patients, give the injectable medicines, which are much more expensive. And but PCSK9 inhibitors and inclisiran have revolutionized the control of LDL cholesterol in the highly resistant patients. There are certain patients who need even other medicines, especially those who have familial hyperlipidemia with very low LDL receptor activity. So we'll talk about that. So achievement of the targets. So this is a reality check when we get excited and we talk of lower and lower levels. And so if you even keep a modest ACC-AHA guideline target of 70, almost 3 in 4 participants did not meet this criteria. If you keep the ESC guideline of 55, not to talk of 40, then 9 in 10 did not meet this ESC criteria. So we are doing very, very poorly, even with modest targets. Remember that the level of 70 was the focus of a paper by Deepak Bhatt et al., where they did meta-analysis of multiple studies, and they showed that 80% of the benefit of lipid lowering will be derived if you reduced the LDL cholesterol to below 70. So when you went from 70 to 55 or even lower, you would get additional benefit. But in terms of the absolute benefit, most of the benefit will be derived once you reach the LDL level of 70. Beyond that, in fact, that paper compared and contrasted that below the level of 70, should you target more lowering of LDL or more lowering of HSCRP? So that is a different thing. But it just shows, number one, that even with modest targets, you will achieve a great degree of benefit, clinical benefit for the patient. And number two, that we are doing very, very poorly. This data is not just Indian data where we know that we are doing very poorly in terms of preventive care, but this is worldwide data and especially Western data. So 3 in 4, 75% don't meet 70 and 90% don't meet a target of 55 milligrams percent. So this is, and then you have data, the Da Vinci data and Santorini data from Europe, where of course they showed that when they made the targets more stringent from 2016 ESC to 2019 ESC, it led to a lot more people becoming non-compliant with their targets. But in any case, the LDL cholesterol achievement target, depending on how stringent your goal was, is maybe 22% in the less stringent trials and even down to 12%. And then the Indian study, smaller study, right at the bottom of the screen, with 11 centers and only 575 patients, 1 year after ACS. So how many achieve LDL cholesterol of 55? A grand total of 21%. So this is, I think, the biggest focus that we should have. In LDL cholesterol has no symptoms, yet this appears to be the number 2 ranked risk factor after another asymptomatic risk factor, which is the systolic blood pressure. And so on both of these, we have to find ways of improving the outcome, and not by ideal treatment of single individual patients, but by ensuring broad compliance. So the other thing is the residual risk. So when you say that you have a 34% reduction in 4S to a 36% reduction in the later studies, etc., which implies that 2/3 of the risk is still remaining. And so that is the residual risk which we are talking about. So you will not eliminate the risk entirely. So this would be with relatively modest targets. But even when you go to supratherapeutic levels and you reduce the LDL down to 53, down to 30, etc., in secondary prevention using injectable medicines, improve it, of course, with ezetimibe, but Fourier with PCSK9, and the REVEAL study with the CTP inhibitor, you still have huge amount of residual disease. So residual cardiovascular risk remains in the lipid lowering trials despite LDL lowering to levels below those generally recommended. So this means that it is very important to lower the LDL cholesterol, but do remember that you will get the maximum proportion of your benefit is there once you have reached the modest levels. Beyond that, be mindful of side effects because some patients will be miserable with those side effects. So do not ignore that part of the equation also. Because otherwise, many patients will be non-compliant. In primary prevention also, similar things. Primary prevention, probably this matters even more because these are people who have not had a heart attack or a coronary stent, and they are even less compliant with the long-term medicine and even with minor side effects, troublesome side effects like muscle aches and pains. So there again, we have to be mindful of the risks and the side effects, even if minor. So HOPE-3 is one very interesting study in this regard. And this looked at patients who were not the usual Western patients. So most of the studies have had bias towards white male population from the West, whereas HOPE-3, led by Dr. Salim Yusuf, looked at other ethnicities and other populations, reasonably large study. And this showed that low-dose statin therapy, 10 mg rosuvastatin in this case, did benefit these patients. I think there is something wrong with this graphic, but this is significant, 3.7% versus 4.8%. So obviously the graphic is wrong, but this is highly significant risk reduction with primary prophylaxis in intermediate risk patients with 10 mg rosuvastatin and candesartan hydrochlorothiazide combination, that is the BP medicine, did not give that reduction. So the HOPE-3 trial re-established after Jupiter the importance of primary prophylaxis in these patients who at least had intermediate risk. Because there is still an ongoing controversy whether the truly low-risk patient, say a 40-year-old lady with no comorbidities, non-obese, non-smoker, etc., average cholesterol levels, should that patient be treated with statin and try to get expose her to the risks of side effects? Maybe not, and there are papers on that. There's one very particular DMJ paper which suggests that maybe those patients need not be treated. But even in primary prophylaxis, if you have at least intermediate risk, you need statin treatment, certainly the high-risk patient, and certainly the secondary prophylaxis patients. Because in these patients, the small risk of muscle aches and pains and also a slight increase in dysglycemia will be greatly outweighed by the beneficial effect on the reduction of coronary events. So intermediate to high risk primary prophylaxis patients and all secondary prophylaxis patients should get lipid lowering therapy, and this should start with statin as the cornerstone. And if we do not achieve the goals, then we should add other drugs. And there should be personalized adjustment because not all patients will tolerate all doses. Look at the patient's absolute ASCVD risk. Ethnic considerations, well, Asian patients also respond, and HOPE-3 also tells us the same thing. There are persistent claims that the Asian patients respond better or worse, or they have more or less side effects. There's not too much difference in either Indian patients or East Asian patients. This is monitoring regular checks of CPK, liver enzyme, and blood glucose. Now, this is derived from one of the earlier guidelines on cholesterol. I would question that because I think these days we don't do it. And in fact, it has been shown that you do not need to have so much intrusive check because these patients will do quite well in large part. And a little bit of muscle aches and pains can be treated clinically. Rhabdomyolysis and actual CPK elevation is very, very rare. Likewise, liver enzymes and blood glucose is a problem, but usually it is a worsening of pre-existing dysglycemia. So for statin-associated muscle symptoms, again, one has to be mindful. Switch the statin, adjust the dose, consider CoQ10, consider vitamin D supplementation, etc., etc., flexible dosing, etc., etc. All of these ways in which one can cajole the patient to take the medicine, despite WhatsApp University telling him that statins are poison, and the so-called nocebo effect, where people are told by their peer group that this will cause you side effects, and therefore they get side effects. So peer pressure and adverse publicity is a very important factor in not taking statins, and this we have to combat. Usually we have an easy path in secondary prophylaxis patients who've already had a heart attack or a stent, because the doctor finds that the patient is much more receptive when he writes the statin. But many times in primary prophylaxis, where the patient has not had any event, you have to really convince the patient, work with the patient and his symptoms in order to let him take at least some statin. And from Hope 3, we realized that even if he took a low dose of statin, he would still be better off than if he did not take statin. So then we have other drugs, and I think this group knows very well how ezetimibe by the specific NPC1L1 transporter reduces cholesterol absorption in the intestines, and it is well suited in its role as an add-on therapy for patients who are not achieving the LDL cholesterol goal. Although the initial trial was based on a combination with simvastatin, but it seems to have stood the test of time, and you can combine it even with the high-dose statins like atorvastatin and rosuvastatin for the patient who's not achieving goal, and also with lower doses of statin in the statin intolerant patients. So it reduces the cardiovascular events in this case, and it is safe in the elderly and even in chronic kidney disease patients. So there are many fixed dose combinations available, including what is going to be talked about subsequently. And then in patients who are truly high risk, especially secondary prophylaxis, but also familial hyperlipidemia, use the very potent monoclonal antibodies, which are expensive, but they are very effective in further lowering the cholesterol. So high-dose statin plus ezetimibe may reduce the LDL cholesterol by around 65%. If you give PCSK9, you might reach 75 to 80%. So there are many major trials, Fourier, Odyssey outcomes, etc., which have shown both the reduction in LDL cholesterol and further relative lowering of the risk profile in these patients. However, when we say that you get another 15% lowering of the risk, you still don't get it down to zero. And so we have to see. And the other problem with this is that it does depend on the patient having at least some LDL receptor activity, because it propagates or promotes the presentation of the LDL receptor at the cell membrane of the hepatocyte, so that this LDL receptor can capture cholesterol. But if there are no LDL receptors because of genetic reasons, then even this PCSK9 inhibitor may not work. And then you may only need things like liver transplant or dialysis. So bempedoic acid is another drug which is especially suited for patients who have muscle side effects of statins. This works on an enzyme ATP citrate lyase, which is higher up in the cholesterol biosynthesis pathway than the HMG-CoA reductase. And since it is not expressed in the skeletal muscle, it doesn't cause the skeletal muscle side effects of pain, etc. The CLEAR outcomes trial, after the HARMONY series of trial, the CLEAR outcomes trial has shown actually clinical benefit of this further LDL cholesterol reduction, which is achieved as. So again, this is a cost-effective, not very expensive medicine, which can be combined with statin, ezetimibe, and even bempedoic acid. So all three could be given And in most patients, it is safe enough. There are some minor risks and infrequent risks, including tendon rupture, but those are very, very rare. So therefore, fixed dose combinations and standalone also, it has been used both for non-achievement of target and for statin intolerant patients. And then inclisiran, which works by a slightly different mechanism than the PCSK9, so small interfering RNA, which achieves the same goal as the PCSK9, improves the presentation of the LDL receptor on the hepatocyte membrane, and therefore leads to reduction of the LDL cholesterol. As compared to PCSK9, this has to be given less frequently. So 6 monthly dosing after the initial loading, as opposed to at least 3 monthly with the PCSK9. So it works out a little cheaper and little more friendly to the patient. Maybe it is slightly less effective, maybe about the same. However, again, you will need some LDL receptor activity. So that intensive lipid lowering with statins will work, has been shown by long ago by the PROVID study, where atorvastatin 80 milligram led to reduction of clinical events as compared to pravastatin 40 milligrams. I think we're all aware of this. And so the recommendations are all quite similar. Target more than 50% reduction in LDL cholesterol for high-risk patients, and patients with recurrent events, you target less than 40. So as I said, remember 100, 70, 55, 40 as per the ESC guidelines. And I think we all know this. I already mentioned it. But of course, if you follow the Lipid Association of India, you will go to even more aggressive targets. You will want to go to extreme risk category less than 30 and extreme risk category C less than 10 to 15. So how achievable, useful this is, how low is better and safe and tolerable and useful and proven. Now, this is a question. If we actually pursue LDL zero strategies, we may encounter, actually, even though we have not encountered yet, we may encounter a J curve in the intensity versus benefit equation. Till now, the good news is we have not seen a J curve where you have brought down LDL level to a certain level and patient's dementia increases. Maybe a little bit of cataract might increase, but cancers do not increase, and dementia does not increase. There is some dysglycemia, we know that. We also know that the muscle side effects are there, but you can't go to zero. For the nerds in the audience, Zeno's paradox shows that even Achilles can't beat the tortoise if he halves the distance in every unit of time. But similarly, residual risk will persist in trials even with extreme LDL lowering. So pursue the greater good rather than trying to reach the absolutely lowest level of LDL cholesterol, remembering that in most of your patients, you don't even reach modest levels, and patients self-check out. After a certain time, they have fatigue and they say, "Bahut dawai kha li," and they will not take your medicine. So therefore, that is the place where we have to concentrate the most, is my view. Very low levels may have benefits. However, the side effects are also well known, some potential, some actual. So, and the barriers, including the muscle symptoms, then the nocebo effect, which I talked about, and the media impact, all of that we've already talked about. So the reality is that adherence drops over time, below 50% by year 2. And cost is a factor, side effects, pill load, no symptom relief. So keep, I think media campaigns help, fixed dose combinations help, keeping the costs down will help, regular visits, listening to the patient, etc., etc. Maybe nurse practitioners calling up the patient, ensuring that the patient has taken the medicine, and then the clinical inertia. Patient walks in, he's walking about, he's asymptomatic, and the doctor does not bother to change the statin dose or add ezetimibe. So that clinical inertia also is a barrier to the achievement of our lipid goals. In our context, we have a lot of mixed dyslipidemia with metabolic syndrome and diabetes. Some of these patients may have small dense LDL. So whether we should be giving fenofibrate to these patients, but certainly we should be giving statins first. And we have early onset disease. However, overall, our patients are similar to the Western population. And now the Indian guidelines are more or less in line with the Western guidelines, especially the recent effort from CSI, led by Dr. JPS Sawhney. I think that is very much in line with the Western guidelines. So that is good. Certainly, as I said, LDL is not the only game in town, and you have to look at inflammation, although it is a work in progress. HSCRP is a good marker, certainly, maybe a risk factor. Canakinumab is still looking for application because it has side effects. And SGLT2 inhibitors and GLP-1 agonists, certainly they reduce risk. What about the antiplatelets? What about anticoagulation in the form of rivaroxaban, etc.? So all of these things, we have to have a multifactorial approach, because with just a lipid-centered approach and LDL-centered approach, you are not going to do the best for your patient, but do good on this pillar. That is certainly the goal. Lower the better, lower earlier the better in terms of therapy. And future trials will include monoclonal antibodies against LP little a, and then newer and newer CETP inhibitors. The earlier ones have all failed. And then in patients who are LDL receptor negative, things like evinacumab might work. Gene therapy for PCSK9, nanoparticles, oral PCSK9 inhibitors, many other things are there. Screening should start early, especially in the high-risk patient who has genetic dyslipidemia, who has a strong family history. You might even do the screening in the neonatal period and in follow-up. School screening, early adult screening. So all of these things are important. And so I think we need to hear from Dr. Piyush Jain as to how to implement the achievable strategies. Thank you.
Yeah, thank you so much, Dr. Agrawal, for that thought-provoking session on LDLC lowering management and taking us through the recent trends and the challenges in the management. Now, I would request Dr. Trehan to please introduce our second speaker, Dr. Piyush Jain. So I will highlight his CV slide now. Dr. Trehan, sir, are you there? Okay.
Does not matter. I will introduce myself.
No, sir. So we have our second speaker, Dr. Piyush Jain, who is Director Cardiology and Head of the Department of Preventive Cardiology at Fortis Escorts Heart Institute at New Delhi, and a pioneer in preventing cardiology in India. He's MBBS and MD from Maulana Azad Medical College and DM in Cardiology from GB Pant Hospital, New Delhi. His key areas of expertise include preventive cardiology, lipidology, cardiovascular nutrition, hypertension, diabetes, and adult vaccination. He has authored numerous papers, including 16 books on health and medicine in English, Hindi, and other languages, and his former editor-in-chief of the Heart of the Matter. He has over 110 scientific publications to his name and 11 book chapters, serves on the editorial board of Cardiology Today and ethics governing boards of reputed institutions. And he's regular speaker at various national and international cardiology conferences with a strong academic and public health impact. So with this, I would invite Dr. Jain for delivering his talk.
And in fact, he's Enas of India. And
not A.
yeah, he spent more than 4 decades of his life as a torchbearer for all of us, and I think it'll be a really good session to listen to him as to how to kind of incorporate a second molecule, which we know is available to us for more than 2.5 decades, but somehow it's not finding its place in the prescription right from the word go, at least for patients who are discharged from the hospital after an infarct. They're receiving statin, but not ezetimibe often. So over to Dr. Piyush.
Thank you very much, Dr. Trehan. So as Dr. Agarwal was giving his very elaborate and revealing talk and giving his personal perspective as well as what is found in literature, I was frantically searching for a book by Arthur C. Clarke. I don't know how many of you know about him, but he was the person who wrote many science fiction, books, and also paved the way for making the satellites which are in use for communication nowadays. So he wrote a very strange book, Arthur C. Clarke's Word of Strange Powers. You may not be able to read it here, and looked into various phenomenon as to what is the plausibility of things like life after life, mind over matter, spirits, blessings, and telepathy. And at the end of this book, I just remembered that he tried to give a credit or discredit to each of these phenomenon in a certain way, which is just like the AHA, ACC, or ESC, recommendations, the class of recommendation and level of recommendation. So +5 is certainly true, -4 is certainly untrue. So this is the end of the book. And he came to some certain conclusions that certain things like telepathy are probably possible. So what is the relevance of this particular book to me and this kind of a scoring? So my personal view tallies with Dr. Agarwal that many of the recommendations and guidelines which are coming from USA, from UK, and then NICE guidelines, and then European guidelines, and then certain Indian guidelines like LAI and CSI. Many of these guidelines are on a very firm, background, and they are supported by clinical investigations. Whereas even in these guidelines, there is a lot of personal perspective. So no wonder that any clinician who is well versed with knowing about lipids or hypertension or diabetes, they will actually make their own perceptions and treat the patients accordingly. Now, my personal summary of my personal perception is that when we are talking of the lipid management in particular, we have got a lot of choices. We have got, statins, we have got ezetimibe, we have got bempedoic acid, we have got PCSK9 inhibitors, and then we have, upcoming molecules like pilacarsen, angiplet 3 inhibitors, which are already there. Some of these are there in the market in the US on a limited basis. But when you are talking about treating a patient in day-to-day clinical practice, you have to think of the patient also first. And we have to think like a patient as to what do I want Do I want to take 4 or 5 medications for just lipid lowering? Because lipid lowering is not the only treatment for heart disease. You have antiplatelets, you have antidiabetics, we have antihypertensives. You may also like to give something for smoking cessation. So list will keep on growing, and the patient may land up with for not even 20 but 30 medications, because they may have some non-cardiac problems. So one has to be very prudent and see what the patient wants. So it's not simply a judgment or kind of diktat to the patient that you have to take this plus that and that. That will create a problem. Now, what is the problem? First of all, the patient will not take it. If the patient takes it, it will be out of reach after a few days and few months, and the adherence will become low. Thirdly, there will be side effects. So you have to be very, very reasonable. Now, what does that mean? That means that you have to differentiate between a really high-risk patient and a patient who does not really require all the medications or combinations which you may like to prescribe, but the patient may not take it. Therefore, I will say that for most of my patients, I will always look at his pocket, his ability and willingness to take maybe 3 medications or 4 medications for lipid lowering. So I will like to differentiate between 2 situations. One is a really high risk situation, and second is a more stable situation. So there are 2 extremes, and I will go rather slow on those patients where the patient is stable and has been doing well for a long time, maybe after an acute coronary event, or maybe he never had a coronary event. And I fully agree with Dr. Agarwal that the reduction of LDL-C below 70 or maybe below 55 is a law of diminishing returns. Now, what is the meaning of this law of diminishing returns? The benefits keep on decreasing as you go more and more aggressive. However, there is a case for combination drug therapy, and to achieve the LDL-C targets according to the guidelines, if it is feasible, safe, and cost effective, and the patient is willing to take it. So, as long as a patient does not require multiple drug therapies for lipid lowering, it is better to dispense away with the unnecessary medication. And I will give you an example of this. And I'm sorry I'm taking a little time, but I want to set the tone of my talk today. So a patient comes to us with acute coronary syndrome. You start with high dose statin, and as per the standard of care, when thought was possible and prudent, you add ezetimibe to that patient also. This is quite reasonable to my mind. This is quite reasonable, and I don't contest that. And during the time of acute crisis, the patient will also accept it. But then after that, what happens is many of these patients, after 2 to 4 weeks, 2 weeks according to LAI and 4 weeks according to CSI, you repeat lipid profile and maybe add bempedoic acid or PCSK9 inhibitor or inclisiran. Now, the question is that if a patient is on high dose statin or the maximum tolerated dose of statin, and the patient is also on ezetimibe, and he's now also being given bempedoic acid and now PCSK9 inhibitor also, why continue with all 4? Why not down titrate other medications like bempedoic acid and ezetimibe at that time? Maybe ezetimibe might be continued, but maybe bempedoic acid should be stopped in case the PCSK9 inhibitor is, but the guidelines don't say anything like that. They only talk about adding, and that is one of the major drawbacks of these guidelines all over the world, and I simply don't agree to that. The second thing is, I don't agree to the fact that all the patients who have coronary artery disease for secondary prevention, you need to reduce the LDL-C to less than 55, because you have to see what will be the benefit. In a given patient, it is impossible to predict whether it will benefit, but there is always a gut feeling on the basis of which we as clinicians work. So a patient who is relatively stable has been coming to us, or maybe has been going to some other doctor. Now he comes to us and has an LDLC of say, let's say 60 or 65, and he has been doing very well for the past 2 to 3 years, and his overall risk does not seem to be very high. There is little point in adding new drugs just to reduce the LDLC to less than 55, just because he has got a coronary artery disease or some other manifestation of so there is no doubt that elevated LDLC is something that plays a major role in, and a causal role in the atherosclerotic cardiovascular disease. But one should not go overboard because of the decreasing cost-benefit ratio as well as cost effectiveness. Having said that, in a deserving case, you need to go more aggressive, and some differentiation has to be made as to whether this patient will actually benefit with very potent medications which will reduce LDLC to less than 30. And I also don't agree with some of the guidelines which have made many classes, low risk, moderate risk, high risk, very high risk, extremely high risk, category 1, category 2. Clinicians don't work like that. No clinician will actually look into that. It is basically on the basis of the number of risk factors, the intensity of risk factors, response to the prior treatment, and the previous history of the acute vascular events. All of these will define as to what is the future course of this patient according to the clinician. Now, having said that, statins, they came first. In India, they came in something like 1993. And since then, the threshold for treatment has decreased. The targets for treatment have decreased. And we all know that reducing LDLC does reduce the future risk. And there is a quantification as to 1 millimole of LDLC reduction is associated with about 20 to 22% relative risk reduction in major atherosclerotic cardiovascular events. But this is a relative risk reduction, not an absolute risk reduction. So current international guidelines, they do recommend very low levels, but one has to see what is the benefit. And I must say that very low levels do not reduce the overall mortality. They may reduce certain, coronary events and cerebrovascular events, but they do not reduce the overall mortality. So, what about the other agents? Now, in this context, I should say IMPROVE-IT trial was a major trial which actually looked into the incremental benefit of adding ezetimibe to high-dose statin, and the statin that was used in this trial was simvastatin, and the patients who were recruited in this trial were not chronic coronary artery disease. They were patients who had recently an acute coronary event. And what was found was that the IMPROVE-IT trial showed that there is a decrease in the coronary events with adding ezetimibe to the statin. And that actually is the main trial, or maybe the only major trial, which has shown that ezetimibe, not on its own, but when added to a statin like simvastatin, gives rise to an incremental clinical benefit. The Fourier trial and Odyssey trial with the evolocumab and alirocumab, that had shown the clinical benefit, event-wise benefits, and other benefits in relatively stable patients with either at high risk, very high risk, or those who had a coronary event in the past. The clear outcomes was with the bempedoic acid, but we are going to talk more about it. What is the incremental benefit of LDLC lowering combination therapies? Actually, Dr. Agarwal has dwelled upon this in great length, But let me just focus on the combination of statin plus the ezetimibe, and you find that a large trial, IMPROVE trial, was a large trial of simvastatin monotherapy versus simvastatin plus ezetimibe with a 6 years of follow-up. And what it showed was that the primary endpoint of a composite of cardiovascular death, non-fatal MI, unstable angina requiring rehospitalization, coronary revascularization, and non-fatal stroke at 6 or 7 years was 32.7% in the simvastatin ezetimibe group as compared with 34.7% in simvastatin monotherapy group. So this was a statistical difference. Absolute risk reduction was to the tune of something like 2%, which means if you treat 50 patients with a combination of statin plus ezetimibe in patients who recently had, it was not an acute, study. It was something during acute and following the acute event during the next few months. You actually reduce the risk of this primary endpoint, which is a composite of all these endpoints, by about 2%. So 50 patients you treat and you get one benefit, which is quite all right. And this is comparable to most of the other studies with other kinds of agents, both lipids and non-lipids. So if you look at the individual individual endpoints, the major adverse cardiovascular events was reduced by 10%, the any myocardial infarction by about 13%, and ischemic stroke by 21%. That is surprising because statin therapy as such actually does not lead to reduction in the cerebrovascular events as much as the coronary events, but it was the opposite out here. That does not matter. So Fourier trial once again was done in patients on background of statin therapy, where evolocumab, PCSK9, was used with, the achieved LDLC was a median of 30 milligram per deciliter and about 2% decrease in the composite of same kind of events like cardiovascular death, MI, stroke, rehospitalization, or unstable angina, or coronary revascularization. And if you exclude certain things like soft endpoints like unstable angina or coronary revascularization, you find that there was about 20% reduction. So what is important to remember about these trials with PCSK9 is that they were the first trials to show that there is a benefit when you reduce the LDLC to low levels up to 30 milligram per deciliter. And therefore, this probably paved the way for change in the guidelines where LDLC targets in patients with high risk or patients who had a coronary event in the past to less than 55. So Odyssey outcomes with alirocumab basically showed the same thing. We will skip this slide. And the trials with PCSK9, to be very brief, showed that the combination of high intensity statins and a PCSK9 inhibitor reduced the number of major cardiovascular events by about 15% in about approximately 2 years in intensively previously treated patients with a mean baseline LDLC of 90 after achieving mean LDLC concentrations of 30 and 54 milligram per deciliter respectively. So guidelines naturally are there to interpret these studies and recommend that we should actually reduce the LDLC by at least more than 50%. And the ESC guidelines talk about LDLC reduction to less than 55 milligram per deciliter. There are some heterogeneity in the exact figures, but it seems that most of the guidelines now talk about reducing the LDLC to less than 55. How low to go, that is the main question. And for that, I think jury is still out, even though recommendations have been made. And as I said in the beginning of my talk today, that one has to actually look into the patient's preferences as well as acceptability, the cost, and you also have to look into the profile of the patient, whether the patient will really benefit from this or not benefit, or maybe the benefit, if it is there, is that does not justifies the price the patient ultimately is likely to pay, because there are so many other things the patient has to take. Anti-diabetic medications, the price is going up through the roof. Now we have injectable GLP-1 receptor agonists costing something like more than 15,000 rupees per month. So the cost of treatment is really going up. So you have to balance the cost of treatment versus the benefit and efficacy. But of course, it goes without saying that the mechanistic studies, like the IVUS studies, have shown with PCSK9 that there is a regression of the plaque. And this is important, particularly because when you give a high dose statin along with PCSK9, you find that there is a greater coronary plaque regression in non-infarct related arteries after about 52 weeks, which is an observation which needs to be corroborated with the larger trials and repeated trials to see the clinical endpoints over a long-term basis, because the duration of the PCSK9 inhibitor trials was not enough. One has to actually look into the long-term follow-up of these trials and observational studies, real-world studies, to see whether actually it really translates into a decrease in the coronary events over the life course of the patient. But certainly both evolocumab as well as alirocumab have shown basically the same thing, that if you add a PCSK9 to statin after a non-ST elevation MI or other coronary event like acute MI, as in case of the alirocumab, you actually lead to a regression of the plaque, more stabilization of the plaque, with increase in the thickness of the fibers cap and other parameters as observed during the intravascular IVUS, and that gives us encouragement to use these on selective basis. Now, what about combination of statin plus ezetimibe? IMPROVE trial was a clinical endpoint trial, but we have other trials which have taken place rather recently, and there was a trial which was published in Lancet in 2022, the racing trial, which was conducted in South Korea in 26 centers. Number of patients here was more modest, 1894, a combination of rosuvastatin 10 milligram plus ezetimibe 10 milligram, and this was compared to rosuvastatin 20 milligram alone. So this was done to look at the long-term efficacy and safety of moderate intensity statin, that is 10 milligram, with ezetimibe combination therapy versus the high intensity statin monotherapy in patients with atherosclerotic cardiovascular disease. And what was found was that the moderate intensity statin with ezetimibe was non-inferior to high-intensity statin monotherapy for the 3-year composite outcomes, with a higher proportion of patients with LDL-C concentrations of less than 70 milligram per deciliter and lower intolerance related to drug discontinuation or dose reduction. So this is not a very conclusive trial because it was a non-inferiority trial, but it gives us confidence that combining a statin in a more moderate dose with ezetimibe in standard dose of 10 milligram may be equivalent to a relatively higher dose of a statin like rosuvastatin 20 milligram per day, and it may be effective in achieving the LDL-C targets, as well as it may ward off the problem of intolerance or non-adherence because of the other side effects. So this is a useful addition to the IMPROVE trial. And if you look at the subgroup analysis of this trial, the benefits were actually observed even in patients with diabetes, those who were at very high risk, and also in the elderly. And this is something that has shown consistent results of the benefit of moderate dose statin, rosuvastatin 10 milligram plus ezetimibe 10 milligram as compared to rosuvastatin 20 milligram per day. There is some evidence for the benefit of lipid lowering therapy with a combination of rosuvastatin plus ezetimibe in more moderate dose in patients undergoing PCI versus rosuvastatin 20 milligram. And in this particular set of patients, it was a real world study of 72,050 patients. The combination was associated with a lower occurrence of adverse cardiovascular events, statin discontinuation, and also diagnosis of new onset diabetes requiring medication than high intensity statin monotherapy. And this was a study which was done in patients who underwent PCI. So there are many reasons why combination therapy may be a better choice. And one of the highlights of combination therapy of rosuvastatin with ezetimibe is that it can be given in a single pill, and one can always alter the dose of statin, and the dose of ezetimibe remains the same. So maybe you could think of shifting your thought process from preventing a clinical event alone to plaque regression, which automatically should take place with a sufficient lipid lowering drug therapy. And one could actually look into adding ezetimibe or bempedoic or both. Maybe I'm more enthusiastic about adding ezetimibe to rosuvastatin because of the large number of patients which were recruited in the IMPROVE trial, particularly in the setting of acute coronary syndrome, and then of course PCSK9 targeted therapies in more deserving cases where the cost actually is justified because of the very high risk. So there are gaps in our treatments for lipids. Ideally, I would have liked that there is a single pill available for treating all cases with the lipid disorder, but that is not going to happen anytime, at least during my lifetime. So a combination therapy is required in many cases, and I must say that combination of statin plus ezetimibe is not something which will be having a huge impact on the pocket of the patient. Also, in fact, the cost comes down, and I find that many of these combinations of statin plus ezetimibe are cheaper than the statin alone, and which is a very healthy sign for the Indian patients who are mostly giving away the cost of the medication from their own pocket. So you have to see the risk. Actually, you have to see the risk, you have to see the pocket of the patient, you have to see what is the baseline LDL-C, you have to see what is the benefit incurred by the prior high dose statin therapy or highest tolerated dose of the statin, and then come to a conclusion as to what else should be given, keeping in mind that the patient may also be having diabetes, taking 3 or 4 medications, some of which may be very costly, or you may also like to see what is the antihypertensive drug therapy. There may be 3 drugs, 4 drugs, patient may be resistant to hypertension control, and you may actually have to look into non-lipid factors which increase the risk, like uncontrolled hypertension, and focus your attention on controlling that hypertension, finding out the cause of hypertension, rather than just having a lipid-centric approach. And I really don't believe that making the things harder for the patient as well as for yourself by classifying and reclassifying and fine-tuning the risk all the time and coming on to a conclusion that you need to reduce the LDLC further and more further, that is not the approach any sane clinician will actually like to do. So I will skip through some of the slides, but I must say that when you are using a moderate dose statin plus ezetimibe, you may actually achieve a reduction in the mean LDLC by as much as 45%. A high intensity statin, when tolerated very well, can reduce the LDLC to around 50%. But in the ideal situation where high intensity statin plus ezetimibe can be used, the reduction is 65%, which is almost similar to what is achieved with adding PCSK9 inhibitor. So endeavor should be to use the highest possible dose of statin plus ezetimibe as a good choice for most of the patients. Now, these Indian guidelines, we all know, and I already talked about it. So I will not talk about these. Or what I will say is, don't look at these, algorithms. These are just for learning and making a mental note of what is possible to do. But classifying and over classifying the risk of a patient actually does not lead you anywhere. You need to set a target and go through the stepwise approach to a highest possible dose of statin, add ezetimibe or bempedoic acid or both, preferably ezetimibe. And if the triple drug combination does not give rise to achievement of the LDLC targets, whatever you choose to decide in a given patient, and according to the guidelines, you add PCSK9. Personally, when I add PCSK9 or I add inclisiran, I like to look at the achieved LDLC closely after about 4 to 6 weeks. And in case the patient has got very low LDLC levels at that time, I don't hesitate to stop ezetimibe and bempedoic acid or both. Maybe I continue with ezetimibe, but certainly I stop bempedoic acid at that time. And differentiation should also be made between acute coronary syndrome and chronic disease. In chronic disease, you can be more indulgent and go a little more slowly. Whereas according to CSI guidelines as well as the LAI guidelines, I agree that one should not wait for 3 months for assessment of the response to the treatment that has been instituted at the time of admission. And one should repeat the lipid profile according to LAI. It should be 15 days. I think that is a little bit too early. 1 month, as suggested by CSI, is something that I agree that 1 month or 6 weeks is the right time. And algorithm actually is very simple. Start with statin plus minus ezetimibe. Mostly ezetimibe should be added at that time, and then add on other drugs as the situation demands. This is nothing but a repetition, and these are the strategies which I already talked. We will skip through all these. Now, there are multiple algorithms in this presentation, and this is not my presentation. So I'm just interpreting. So I'm not repeating all these algorithms. Those who are interested may actually look into this. So I will conclude because we are running out of time, and it is already 20 minutes past the stipulated time. So LDLC reduction is a cornerstone of cardiovascular event prevention and plaque lesion treatment. I agree with that. Having said that, LDLC reduction is not the only thing. Dr. Rajiv Agarwal talked about lipid reducing, parameters, not only LDLC, but non-HDLC, ApoB, etc., etc. To add to that, non-lipid risk factors also need to be assessed and addressed to very carefully because they are also equally important. Then sooner the LDLC concentrations are achieved, as per target, the better for the patients. Now, here you may differentiate between acute care and the chronic coronary artery disease. So for a patient who has landed up with acute coronary syndrome, this is important. This is very important, no doubt. But for chronic patients who are stable, you can go a little bit more slowly. And I don't agree that you should consider and institute all available lipid lowering therapies. Consider, yes, but adding more and more drugs is not my cup of tea. And a combination therapy like rosuvastatin plus ezetimibe or some other statin plus ezetimibe is a good combination. And it does achieve LDLC targets in a great number of patients. So this combination therapy is the talk of the town nowadays. And this is required more often than not in most situations, because there was a time when we had only statins showing the evidence of benefit, but now we have got evidence of benefit for many other agents for LDLC reduction. And it should be kept in mind that whenever it is required, it should be instituted. When it is not required, it should not be instituted. When you add more and more drugs, think of cutting off certain drugs which are non-essential, which may include the non-statin and non-PCSK9 inhibitors. Thank you very much.
So thank you, Dr. Piyush. I think it was a very elaborate discussion, and what I will say, it was a kind of a bipolar talks. Like when Dr. Rajiv was speaking, he was talking about huge burden of atherosclerosis, and he was talking about the biggest villain as villain being the systolic blood pressure, but the next close is the LDL. And he said, do everything, whatever you want to do to take care of LDL. And according to him, even in the best of the centers, the LDL reduction is not achieved in most of the cases. About 3/4 or even 90% cases do not achieve that. And he went on to say that try and decrease it. If one drug works fine, add another, add another, add another. Go to injections, go to stronger injections. And pill burden has increased, the cost has increased. And finally, he said that even if you do everything for LDL, you still have significant residual problem. Then comes Dr. Piyush and he talks about more pragmatic things, more practical things. He starts to look at the pocket of the patient. He tries to look at the number of the pills and the misery of the patient. And he tries to have a somewhat practical approach where he tries to say that, well, try to decrease the LDL, and something close to 50-60 is okay for him. And for that, he'll be happy to be aggressive in ACS, but will be relatively cool in handling patients if they're in chronic CAD. And his goal will be somewhere around 50-60. And he'd like to add maybe one drug and sometime a second drug. Not very keen on being aggressive with injectables, injuring the pocket of the patient. And I think that part is also important. But my question to Dr. Piyush, if let us say cost is not a constraint, will you like to add more drugs?
Not really. The point is that if a patient is on maximum tolerated dose of statin and he's also getting ezetimibe, and he's now getting bempedoic acid, and you add PCSK9 or inclisiran also.
Let us just short about, let's be short about only oral drug. If you have a combination of three oral drugs, where you have a statin, where you have a statin plus ezetimibe plus bempedoic acid, and coming is the time when you will have oral PCSK inhibitors. So are you more worried about number of the pills or the pocket of the patient or the misery of a patient, or you are worried that you are likely to receive get to a J point with LDL reduction, and it is possible that beyond 50, if you get to 40 or 30, you are likely to get some problems. See,
No,
the
no,
literature says,
I'm not
literature says up to 30 is no problem, and
So-
even zero LDL, there have not been a significant problem. And if you look at kids who are born with a very small LDL, LDL is something which we keep adding onto us with our lifestyle. And a 30 LDL is just good enough to do most of the functions. Your cognitive functions are okay. Your hormonal synthesis is okay.
Okay, so should I respond now?
Yeah, please.
So, I mean, I have no objection for triple drug therapy with the maximum tolerated dose of statin plus ezetimibe plus bempedoic acid. That may translate into 2 pills. That is reasonable, and in future it is possible that you may get 3 drugs also, 3 drug combination also. So a single pill, it will reduce the cost, and it will also improve the adherence because the patient is getting 1 pill. But then my main objection is that if you add on PCSK9 inhibitor to that also, that becomes an overkill. And in that situation, you should attempt at least to reduce the number of pills by uh, shaking off bempedoic acid to begin with, and maybe ezetimibe also. Now, coming on to the question of J point, I don't believe that we know what is a J point. Now, for example, it has not been studied actually very properly. I will give you an example. There is a condition called A beta lipoproteinemia.
Yeah.
Now A beta lipoproteinemia, the LDLC levels are zero. Now,
Zero?
what happens? Zero, yes. Now,
Yeah.
what happens to these patients? You find the clinical profile of these patients that they have got severe fatty liver. Why does that
Yeah.
occur? Why does that occur is because whatever triglycerides and other lipids are entering the liver or getting manufactured, they are not really getting into conversion to the lipid particles which are taken out of the liver and go into the circulation. So as far as the other tissues are concerned, they are able to manufacture their cholesterol, but there is an accumulation of fat in the liver, which may actually, we don't know. We as cardiologists have not studied this particular problem as to what happens when the LDLC levels are zero. So one has to go into a study of conditions like A beta lipoproteinemia where LDLC is zero. What happens to these patients? What is their lifespan? What is their morbidity? Nothing has been discussed in cardiology forums. So we are completely ignorant of all these things. And I suggest that we should all go and I mean, sit down sometimes in some meeting and discuss before saying that very low LDLC are okay. But maybe up to 30 is okay because some LDLC is available, right? So some LDLC is available. So there is an outlet. But in A beta lipoproteinemia, there is nothing. So we are actually creating a system by reducing LDLC to zero in certain cases. Which is just like A beta lipoproteinemia. I don't agree that we have enough evidence that it is safe.
Yeah, to that point, to the point of zero, I definitely agree with you, and certainly we do not know the J point. But I think there is sufficient evidence to show that till 50 LDL, I think most of the people tolerate, and even in our practice, we see that they do very well. And with literature showing as low as 30 is kind of acceptable. The only thing is, are we able to reach there? With the present system of treatment, well, in most of them, we are not able to reach even LDL of 70. That's there in vast majority of the cases. And I think we still
May I come in? May I come in,
yes.
sir?
Yeah.
So I feel firstly, sir, Dr. Trehan, I don't think that was the message that I gave, that go lower to zero. I didn't say so, and I strongly feel that on this issue, it is more a problem of implementation of even modest guidelines that we are manifestly failing to do, rather than the amount of time that we spend on discussing whether we should go to 30 or to zero, because those are really extreme levels. Even at extreme levels, you will not get a zero residual risk. So there is not much point pursuing that, especially when we are not able to achieve even 70. And achieving 70 is a management problem. It requires systems of care which we are just not able to deliver. It probably requires some kind of public health approach where people don't have to pay out of pocket. And in our, the payer pays system where the treatment depends on what the patient perceives as his benefit. So therefore, the patient will treat his fever, the patient will treat his chest pain, but the patient will not treat his cholesterol levels, what to talk of his sugar levels. So therefore, I think this is an implementation problem. And so I feel that fine. Yes, we have these goals of 55 and 40 for patients who have coronary events and recurrent coronary events, but it's more important to achieve the goal of 70, and we are not doing so. And even the current oral medicines like the high intensity statins plus ezetimibe and maybe bempedoic acid will achieve this in 90% of our patients. uh, Maybe not all, but it will achieve at least 70 in most of our patients. So it is more an implementation problem, uh, rather than discussing strategies of starting inclisiran in the ICU in an ACS patient, because those things have all been talked about now. So this is what I feel. I feel we should first achieve the modest goals before we go to these extreme levels. And even in the patient who is cost agnostic, the kind of patient that you talked about, there will be side effect issues when you and fatigue with multiple pills and injections. When you give the patient three injections and multiple pills, so I think we are all on the same page that we have to keep practicalities.
So what is actually required is implementation of the current knowledge rather than adding more and more to the knowledge which cannot be implemented.
Agreed.
Yes, I think so.
Agreed.
That would be a fair summary. That would be a fair summary. And even in the Western countries, the achievement of lipid guidelines is so poor. In India, it is
Yeah,
poorer.
that's what you showed. That 3/4 of the ACCHA and about 90% of the ESC people
Yeah.
are not
And
able
if
to
you
achieve.
see
Yeah. So
the Da Vinci, then followed by the Santorini data, and then the comparison that what happened when you went from ESC 2016 to ESC 2019, all you did was made a few more patients as non-compliant. But Deepak Bhatt's paper showing that beyond below LDL 70, it's more important to pursue inflammation or than to pursue the LDL cholesterol. I think beyond a point, it's like saying,
right.
should I have one wife or should I have a harem? I mean,
So
so I feel that we should talk more implementation than uh, extreme idealistic approach for one individual patient.
so finally, if we have to summarize the whole talk, Rajiv, how will you summarize? Because Dr. Piyush said just 2% if you add ezetimibe, just 2% if you add bempedoic acid, and those kind of things. It was looking at as if it just a peanut. You may add whatever. So just be happy with giving some statin and bother about the
No,
patient's pocket.
I don't. No,
And bother.
I think it's better than that. I think it's better
So
than that. We get measurable reduction of further reduction of cholesterol when we add ezetimibe. And the interesting point in this is in racing trial and other trials where
yeah,
rather than increasing the rosuvastatin dose, you would
yeah.
rather give the
Yeah,
combination drug, and that would reduce the side effects while
I,
being equipotent or more potent.
yeah,
And
I think
bempedoic acid added on to that.
I
And
quite agree with that. In fact, I'll say that a lot of people will keep saying that, well, you are totally intolerant to statins. So I think rather than saying he's intolerant, so don't give, maybe you try the lowest possible dose, like 2.5 milligram of rosuvastatin given every other day or twice a week, because the smallest possible dose will still give you enough effect. If you keep
yes,
piling up the dose, means then doubling up the dose doesn't give you a double response. So I think
exactly.
just keeping in mind that we have to treat them, and while we are treating them, do not hesitate to kind of combine drugs so that the side effect profile is less. And I think if the industry is coming up with pills which have combinations, it may be pretty easy for patients to take. And I think a lot of industry people can take care of the cost. Like with statin, the aspirin is free. Similarly, with one salt, the other salt is free. I'm sure with the coming time with competition, we are going to have 3 or 4 drugs just in one pill, and that may be more practical and maybe even cost effective. But as far as the goals are concerned, I don't think we should scientifically stay away from the goals. The science has shown that the goals are presently at least close to 50 LDL, and I think the endeavor should be
Fair
to
enough.
bring it down. Bring it down, but be practical, as has been alluded to by Dr. Jain.
Right, absolutely.
So I think in the interest of time, most of the people must be waiting for dinner. We close the talk and thank all the audience and the 2 eminent speakers. Thank you very much.
Thank you.
So,
Thank you.
thank you so much, sir. And on behalf of Nexa Division of Intas Pharmaceuticals, I extend my heartfelt gratitude to all of you for being a part of this enriching session of Lipitas lecture series, the first ever session. A special word of thanks to our esteemed speakers, Dr. Piyush Jain and Dr. Rajiv Agrawal, for their insightful presentations and thought-provoking perspectives on lipid management and cardiovascular risk. We are also very grateful to Dr. Vijay Kumar Tilhan sir for steering the session and with such depth and direction. And your presence and guidance have been truly instrumental in bringing focus to the key clinical takeaways. And I'm also thankful to all the attendees for taking out your time and engaging in this Lipitas lecture series. And special thanks to my sales and marketing colleagues of Nexa division of Intas. And I'm also thankful to the tech support for the seamless coordination. Once again, thank you so much and wishing you all a very pleasant evening and good night. Thank you.
Good night to you. Thank you.
Thank you.